Hello and welcome to Everyday Oral Surgery. This is your host, Dr. Grant Stucki. I am an oral and maxillofacial surgeon practicing in Denver, Colorado. The goal of this podcast is to connect, learn, and inspire. In this podcast, you'll be hearing from OMS surgeons all over the globe discussing ways to improve the practice of oral and maxillofacial surgery. Most information shared in this podcast will be based on personal experience and opinions, so please supplement what you learn here with approved research studies. Without further ado, please enjoy today's episode. All right, everyone, welcome back to another episode. Thanks for listening. Today I'm with Dr. Richard Akin. He is an oral and maxillofacial surgeon practicing in Louisiana. Rick, thanks for joining us on the podcast again.
Great to be here again. Awesome topic.
Yes, excited about this. So we've been doing some topics together that I feel like are important. You know, they're not maybe the past ones we've done are, I don't know where do you categorize them as, maybe social or kind of mental type stuff. Today I wanted to do a little more technical one, but I think this is really applicable to probably 99% of our listeners and what they're doing. So let me just start with this kind of intro story, I guess. One analogy and one story. So there's a concept in physics called Hawking radiation from Stephen Hawking. And it's the idea that black holes might emit a faint radiation that contains information about what fell into the black hole. As part of the kind of the black hole information paradox, which is the possibility that what looks like nothing's there, or what looks like everything has disappeared, might actually still have intelligible information, right? There might still be something there we don't quite see at first glance that can tell us a lot about what happened. And the equivalent in oral surgery, I feel like, is the extraction site. And in fact, it is kind of a black hole, right, so to speak. It's dark. It's kind of easy to ignore. You just feel like there's nothing there once the tooth comes out. But I think on second glance, we'll see that there's more there that you could learn from than you probably thought initially. And this concept was brought to my attention when I was in my first year of residency, and I was doing anesthesia for my chief resident. His name's Ryan Shepard. He's just an awesome guy. He practices in Georgia. Anyways, he was taking out number 32 and took the tooth out real fast, and I thought, wow, that was awesome. And he said, hey, he kind of held the retractor and said, come look over my shoulder and check this out. And he pointed the light into the socket and suctioned it really good, and he said, do you see that little score on the lingual plate? And I was looking, and sure enough, I could see a line, like a mark on the lingual plate. And he said, that's where my burr went too deep and it scored the lingual plate. And, that's an error on my part. We're really trying to avoid, of course, scoring the lingual plate. We really just want to cut maybe 2/3 into the tooth and then crack it half the way with our elevator. That way we don't get anywhere near the lingual plate. As we know, the lingual nerve is there. I'm being a little more explanatory with this because, Rick, we have a lot of dental students who listen to this, and so I try my best to explain this in terms that they could understand as well. So anyhow, that was really cool to me to kind of think, wow, if you stop and pause for a second, there's a little more there maybe that you could learn from. Kind of like, how athletes review game film after the fact and say, oh yeah, in basketball, we should have set a pick there. We should have watched so-and-so who's on the baseline, same idea with the extraction socket. Have you noticed this concept in your career? And if so, how have you applied it?
Well, I've definitely noticed it. Until you came up with this topic, I really hadn't thought about it in the terms of, an active learning tool. It's more of for me, it was kind of like I don't know, just kind of a built-in way to assess my work. But since you mentioned it, I've been paying a lot more attention to what's happening, in the socket, and to give me, to help give me that immediate feedback on the quality of my judgment. Really, I think I really, you made me think back to residency in a number of times where I had, it seems like maybe in oral surgery residency, it's hard to get a lot of feedback um, on extractions. A lot of the times we're kind of doing this on our own. We're kind of like, we're dentists now, and there's more exotic things to teach you. But, really most of us really need to be good at taking out teeth. And the way to do that is obviously we have to do a lot of it. But I think that, the bigger theme here is self, we can call it criticism, or self-reflection on what we're doing in dentistry is the most important thing to get better, because we don't there's if you're doing stuff on the face, I mean, patients can give you pretty good feedback on that, right? I mean, if you've got if you do a genioplasty and you've done a good job, and it's pretty obvious, you can see, you can judge your work and other people can judge it.
Yeah.
In the mouth, it's really not, we have to judge ourselves because most patients can't, at least in the surgical world. Most of the stuff we do is not visually appreciated, because although the crowns that go on top, sometimes we might be thanked for what things look like, but most of the time it's behind the scenes. So
Yep.
back to your point, that as you do these cases and you choose your first, talking to residents or students here, anybody really, as you get out into practice, I mean, I feel like you choose your first cases and you plan them out, and as time goes on, you get busier and busier. What are you doing to learn as you go? And that's really what you're talking about here, is learning from what you've done to the socket. There's this guy I ran into recently, actually, and this is the first time I'd heard this before. And he said, he's an instructor at the dental school, and he said, the bone belongs to the patient, the tooth belongs to you. And I thought that was pretty cool, because if you really are assessing your how you're taking out teeth, the amount of bone you leave behind is as important as what you take away. So,
Yeah, I love that.
yeah, I really did. And so, when you think about it, obviously, when we're talking about third molar surgery, we have to take away bone for visualization. It's just necessary to do in many, many cases. Also, to expedite the procedure, I think that doing a flap and having a big enough flap and taking away the bone that you need to be to get in and out of that third molar socket as quickly as you can, meaning, I should mean efficiently, and we all know that goes into how patients recover, and all the other things that go along with good, surgical skills, and well, this comes down to your assistants too, and your equipment and all that stuff. And so, so yeah, I mean, I think that this is a great thing to be conscious of, and there's lots to gain from any extraction socket, really. And then, but to me, I feel like when you take out the tooth, I love to go back. Like, if I've got students that come to my practice, I have some that work for me, and then sometimes they'll ask questions, and then we'll go up to the CT scan if I took one, or the Panorex, and we'll just look at the root morphology and see what we can learn from that, and see what we missed or didn't miss, or why was that so hard, or why you know what I mean?
Yep. Here's a list. I'll share couple points of things that I look for on the socket, and then I know you've got yours as well, so we can run through that. So like I mentioned, that probably a big one is just looking for burr marks, right, on the lingual plate especially, but also I look down on the floor and I'm looking at burr marks there. I look for cracks. Let's say you've got kind of a lingually inclined tooth and you're really elevating and cranking on a portion of the tooth that's still stuck in there. That can potentially crack the lingual plate. It can crack the distal, kind of the distal coronal bone. So I think that's important too, to see cracks. And then, like, let's say I see a crack running through the lingual plate once the tooth is out, I'll take my periosteal or something and kind of press on it, and just to see how mobile it is. Because if it's a whole segment, pretty darn mobile, that's cracked and loose, then oftentimes I'll remove that fragment or loose piece of bone. There's nothing worse than, I feel like, I'm sure there is worse, but it's very annoying if I feel like if you leave a loose fragment on the lingual and then over time that starts to exfoliate. I'm sure you've had this experience. Patient comes in 2 weeks later and there's this bone spur like working itself out on the lingual. Like that drives patients absolutely nuts. I don't know why, but it's like their tongue is rubbing on it and people act like they're dying, right? And it's this little 2 millimeter piece of bone that's working itself out. But I feel like if you are the student of the socket, so to speak, and you catch that at the time of extraction, you could save your patient sometimes 2 or 3 weeks of agonizing pain dealing with that loose fragment coming through the lingual. I also check. Let's say you have a totally horizontally impacted 32 or 17. And then what happens, I think, is if you section the crown, oftentimes, let's say you go through the CEJ and you're kind of trying to take the whole crown off first and then get the roots. Oftentimes, if you're going too deep and you're sectioning too deep, you start cutting into the kind of the marrow bone that's under that horizontal crown. Trying to explain this anyhow, then you get the tooth out and then you see that burr mark on the floor and kind of all that marrowy bone that you cut into, and now that just means there's a lot more bleeding. Maybe it's not necessarily gonna hit a nerve unless you go real deep, of course, and you could hit the infraalveolar nerve, but usually just cutting too deep into that marrow bone under the crown, you got more bleeding, it's more swelling, more pain, that type of a thing. And then I pull my retractor out, I see where the flap lays, I see if I rip the flap, I'm looking for all sorts of things that tell me a story of what I was doing on retraction. Should I have made the flap bigger? Was it too big? Is it, if it ripped, oftentimes if it's too tight and I'm cranking too hard on the elevator or the Minnesota, it will rip on that mesial space where it was connected. Because usually I just go to the mid second molar is where I make my incision stop, and then I'm retracting. But if I retract too hard, it will rip. Kind of do almost a releasing incision type rip. And I hate seeing that. That just ruins my day sometimes. And it really bothers me if I have a rip like that. But what's your list? What's on your list of things to check out?
Well, I mean, I really like the whole idea of the flap, your flap tension, and what you're paying attention to. Because sometimes you just got to stop and expand your flap.
Yeah.
I think that my assistants will. I don't know. I can almost feel them see like if there's a flap tear, like you said, or I'm putting too much pressure on it. I think that, our only feedback in our other eyes on these things is our surgical assistant and the skills that they have. I don't want to, and I don't want to, underemphasize how important it is to have, if it's a difficult case, to have the right assistant in there with you. If you have, a couple, like I know I have one that's much better for more delicate stuff. Let's say we're doing an expose and bond and likes that. And then I've got another assistant that's better at, she likes more, oral surgery stuff. You know what I mean? More in the back where visibility is low and is very good with suctioning and knowing where and when to suction. So yes, the flap thing. I mean, I'm with you. I would say that at 9, maybe 8 out of 10 times. 9 out of 10 times, I'm not going into the mesial papilla of the second molar to extend the flap. Most of the time, I'm not. I think that when I have seen students remove teeth, I do think that in those cases, I would much rather them extend the flap to get better visibility of the bone, because it's a three-dimensional thing that we put together over time as you operate in the third molar region. We over time, you know what I mean? We get this. It's almost like you get this. I went through a wave in my practice where, it was all Panorex at first, and then it was like a lot more CBCT, and now it's a lot more Panorex because I don't, now I'm more selective on dental alveolar cases about who. I mean, that's just me, and I think there's no, of course, I think it's important to state that you need to get the information for your patient that you feel is necessary.
Yeah.
There's no such, so if you're okay working with a periapical that came from the dentist, I would strongly discourage that for so many reasons. But and sometimes we do get some pushback from patients about taking more X-rays. But there's ways to say it to build that value for what you're doing with just even a Panorex in your practice. From there's just anyway so many reasons that's almost probably a topic in and of itself is what's acceptable and what's not to request that we have in order to take care of our patients. And anyway, that's as you get more and more experience, you can keep that. That Panorex becomes just a tool, and then when you do your exam, you look at your pan, and then you kind of know what's going on. You put everything together in your mind three-dimensionally. Now, if you need it, if as you get started, I think that it's great to get scans on all your patients to see where that tooth is and its positioning buccolingually. I think many times. I remember when I first started seeing my dad take out wisdom teeth, when I first started understanding about removal of teeth, maybe third year of dental school, and I would watch, I was like, wow, it's so buccal. This is so much more buccal than I thought it was going to be. I remember that being the first thing, you know what I mean? I was like, gosh, how do you know it's so buccal, or anyway, so that's one thing that I think that your cone beam will help a lot. I mean, I will say that when I do get a periapical, there's good information on that, and it's the right tooth, and everything's it's all those things have it's just one more good piece of information, because sometimes you can tell maybe there's hypercematosis on the tooth, or not a third molar necessarily, but another tooth. It can help give you clues as well. So, but I would say that that as time goes on, the more conservative we are with our flaps, the better. But early on, the more conservative we are, I think there's you maybe can have worse outcomes, as far as not outcomes, but more swelling and more time.
Yeah. More tears. Yeah.
Mm-hmm.
For
Definitely.
Sure. That reminds me of Dr. Marks. Dr. Marks, he would always say the quote, see well what you do so you can do well what you see. And that was, I think, directed a lot towards residents, and the concept as a teacher and attending. It's like, okay, well, let's make a bigger flap, see what we're doing, avoid tears. Let's start there, and then slowly kind of whittle it back down over time.
Yeah, I like that. I hadn't heard that. I mean, that's really what it comes down to in surgery is, your visual. I mean, you have to have good visualization, and if there's bleeding, excessive bleeding, if there's a deep dark hole and your illumination is not right, or the suction that you're using is wrong, is too big, or isn't it doing a good job, or you need to stop, and because the patient's blood pressure is too high, as you're monitoring them, or the patient's not comfortable, all these things go into how you perform, how you perform in surgery, and I think that, like for me, I think maybe I've been using loops I just have a wide field of view loop, a 2.5, and I just love them. I can see really well. I've got, you still have to use your peripheral vision, but I think that I don't think that maybe some people don't use loops for surgery, but I knew early on I wanted to see everything that's going on. You kind of watching the patient, and now I can do that with a wide field of view 2.5s that I'm using, and the visualization is great because the light is just awesome. So that's another thing. It's just get in there and see the anatomy, look, and do good flap exposure, because that's all of that is practice too. You make a bigger flap, you have your exposure, you have more time, you get to suture, you're getting better at that. So all those things are helping you put together all these pieces until they become part of you, part of your day to day.
Yeah, exactly. The other thing too I was going to mention is, maybe this is just my technique, but I think a lot of us, when we're elevating that tooth, especially like a horizontal or mesioangulated mandibular third, a lot of it's getting in between, the second and third molar, elevating, and we're kind of trying to push the whole third molar distal and crustal. And oftentimes as you're doing that, after you've sectioned it and you're pushing it, that whole process creates these cracks and kind of bone fragments on that distal crest, kind of right under your flap. And I think most don't worry about that, and they probably just exfoliate or come out or whatever. But I always check that at the end, look, and I even sometimes rub my finger right on that, like, distal, kind of right where the hockey stick starts its it starts its buckle hockey stick, like, movement buccally, right at that corner. I'll kind of like put my finger there and rub just to make sure there's not a sharp fragment there, because oftentimes there is, and I want to get that out. Right, I'm just trying to do everything I can to make this a comfortable healing for the patient, because I feel like if you're leaving sharp little fragments, even just 1 or 2 millimeter, to them it feels like a battleship is in there. It can be very annoying. So it's just been part of my refinement process to check all these little things before I move on. And I think it's hard for us. I think this is a concept too that, like, maybe we don't pay attention to, but as soon as we get that tooth out, there's maybe some dopamine hit or something, and yes, we did it, and the thought is we're done. But it's almost kind of hard for us to kind of, well, let's stop. Maybe we're not quite done. Maybe there's a little more here. Let's examine it. Let's do this. Let's move. And I think sometimes too, attendings teach us to curette and irrigate just for that purpose, just to keep us in the socket, kind of looking around, because we want to move on so quickly once that tooth is out. I don't know. What do you think about that?
Yeah, I have strong feelings about that, and I think that you're right. I think that you get the tooth out, especially if it's a difficult tooth, and you really did it. Let's say you did a really good job, and sometimes you're ready to move on to the next one. I don't know. What's your, just real quick, what's your order of wisdom teeth removal?
I do 1, then 32, then 16, 17. I know there's different reasons. Mine was just the local takes effect quicker, I feel like, on those maxillary teeth, and so that's where I start. But I know for sedation, a lot will do the mandibular first, because they don't want that blood flowing down from the top, down to the throat. And so I think there's a bunch of reasons to do one or the other. What do you do?
I start on the right side as well. I just go 32, 1. I'm a lower first. I don't know. When I got out in practice with my dad, I watched how he did it, and I kind of that's been my thing. And I think the bigger point of this, even having this little sideline here, is that you're doing it the same way every time. Because if you're, and that really is, gosh, I've had this just recently. I feel like I've had 3 third molar surgeries. So it's been, you know what I mean? And when you get in the zone and you're in a third molar zone and you got a tooth that's not there, I mean, that's where your assistant is like, needs to be able to, say, you do your timeout at the beginning. Our usual thing here is, we mark off on the x-rays in the room on a big screen. So I got like a 32-inch monitor with the x-ray up there. The Panorex is always visible to me, and then behind me is the CBCT if I need it, and then we can switch them up as needed. So I've got like a 2-monitor setup, and then we'll mark off the tooth, which ones we're taking, and at the beginning we'll identify those teeth. So I'm looking straight at the teeth basically on the x-ray. And then the assistants will remind me too, right before I start injecting, where we are. And I'm sure you do the same. I mean, that's where you need to be open communication, and we all know we're in the same, we all want a good outcome, and when things are fast, and if somebody sees me thinking about giving because they know what it looks like when I'm getting ready to give a buccal block or whatever, and there's no number 17, they know that, and it's like, whoa, and so, you know what I mean? I mean, that's a real thing, and that's back to your question. I mean, I think that, and my point is that doing things systematically every time is a good way to get, because then And just the same thing with how we give local. I mean, I'm sure we all have our ways that we give local and it works best for us, but sometimes we need to tweak that. And so really to your point, at the end of, you get that really, let's say you get out that really hard 32, and then you're going over to the other side, and this tooth is going to be easier, and you're right, you do. I never thought of that either, but maybe you do get this little rush, and your assistants are like, if it came out really good and everything was just, you have this perfect operator sites, and it's great. And you're just not really, you're excited. You think you did a good job. You hope you did a good job. And then you might miss a little detail.
Yeah.
And so that's where sometimes, like you said, I mean, I'll even open up the flap a little bit. Like if there's a little bit, I find that for me, it's usually on the distal buckle of the second molar. Sometimes there'll be a little spot there where there'll be a little splinters of bone. So sometimes I'll just take my number 9, open that up a little bit. You know what I mean? Right in the distal buckle of that dense bone right there, or even further back. I'll just open it up so I could see the ramus and really flush it out really good. You made a good point about, irrigating the heck out of it. Those little details, I think that the biggest thing to prevent complications. Now, I don't know if there's anything that's written up. I haven't read about like what is the most common cause of a subperiosteal abscess. I don't know if there's a particular surgical technique that is a higher risk of that, but those things that come in and they blow up overnight, and you got to do what you got to do to get to deal with that. But to me, smoothing off those little bony fragments like you're talking about, maybe even sometimes if it's, let's say the tooth is real buccal and then the ramus, and you've taken away a lot of buccal bone and it's really thin there, you know what I mean? And there's be like a little void. So what I'll do there, if there's a void in the bone there and I can see the masseter, I'll just go ahead and, I know this is just my tech. I don't know if this matters at all, but I will just take off a little bit of that and smooth it, extend my flat, get my Minnesota in there a little bit deeper and just smooth it off. And then it just gives me the ability to visualize. I don't want to get into the tendon, but I want to make sure that I've got everything smoothed over, because those are, like you said, these little bony fragments, I think can be a nidus for something, even if they're not aggravating to the patient. I think they could be, an area where, I don't know, it's just, I feel like that the mandible especially needs to be smooth. We haven't talked about the maxilla. I think most of our stuff and the vast majority of our complications are on our issues like you said, like the bony spicula issue on the that drives patients crazy on the lingual, the third molar or second molar regions. The upper, I think the main thing is, at least for me, it's, if there's a tuberosity fracture, if there's if one of those kind of things, many times I feel like, and I'd like to get your thoughts on this. I was thinking about this is bony fragments on the, after a maxillary tooth removal. Sometimes you just keep on picking them out. I mean, at the time of surgery, and it's like, well, how far is too far? How much do we need to take out there? And what are your thoughts on that?
Yeah, I mean, that's a good point. And, I think I'll check it, see if there's any bigger fragments. I think if you have a tight flap and you pull your retractor out and it all kind of tightly goes back to where it was, I think looser fragments, the thought there is that they're going to kind of remain immobile in a tight flap and that it will heal. And I think that's why bony fragments are so more noticeable and annoying in the mandibles, is probably because you have the tongue there that's constantly moving that lingual flap back and forth. And I just feel like bone doesn't heal when there's any mobility to it. So if it's moving at all, it will become annoying. It will exfoliate. But in the maxilla, I think it's just much more immobile and can heal better. So that, I don't know, that's one where I would potentially leave it if maybe I put my finger there, there's nothing sharp, it's not super loose, then I would potentially leave fragments. What's your philosophy on that?
Same thing. I think the only thing that if I see loose fragments and I have good visualization of the area, I'll go ahead and get those out. I think as they get more and more palatal, I'll kind of, like you said, I'll leave them alone. And I like what you're saying about, when there's mobility or something that's mobile, like the tongue, particularly in the mandible, that's when patients are feeling it. Or I have had cases, and I'm pretty fastidious about making sure that if it's a maxillary third molar case, that I have to do a buccal trough, and I always check the the most apical area on the buccal to make, because sometimes if you do your releasing incision back there and there's a little ledge of bone, you know what I'm talking about? There's a little
Yeah.
ledge back there. And I have had a few patients that'll put their tongues up there and it'll drive them crazy. And then it's very rare. I mean, I'm thinking about, maybe I learned my lesson early on. So I'm always checking that with either my finger or just making sure that when I put my Minnesota back there, there's not a little ledge of bone that I need to grab, that which is buccal and apical, after I do a buccal
Yes.
trough under the upper. So that would be the main thing. And I think what you said was really good too, is if the flap is, if it, kind of drapes back into its normal position. I mean, do you need a stitch? Do you not need a stitch? That's decision making is up to the surgeon, of
Yeah.
course. And I think many times, we can overdo it maybe with stitches, and then other times, if anything, one stitch is fine back there. Usually, I don't. I never make a releasing incision on the. I'm not a mesial releasing incision, although I've seen that approach many times where. Well, I've seen it before where you make a mesial release, and a distal release to get up there and to get a real deep one. But I don't think I've had to do one. I've always just extended further anteriorly or mesial if I need to get to a really high one, and
Yeah.
then, and what I'm saying? Do you ever do that?
Yeah. Yeah. Same idea. With I mean, I was probably taught this in residency, but I usually do take my mesial incision, to the papilla, and I'll release the papilla between
Hmm.
second, is it second and first molar? Because it seems like if there was a lot of conflicting thoughts on this one, I'll tell you, my residency, we had one attending who said do that, and the other attending, when he saw us doing that, as actually Dr. Maloro, he would say that was completely unnecessary, and we get really upset. But I think it just depends on, you probably over time know your retraction level, and if you keep tearing flaps and there's a
Mhm.
mesial tear, then I think you do probably need to pop the papilla between second and first molar. I mean, that's probably not answering the question you had, but how does your
No, it
flap?
is. It is, because it's getting the visualization you need as a surgeon. It isn't about what's right or wrong. There is no, and that's the thing. I mean, there'll be dogma and people will be dogmatic about this, but get in there, do a mesial release if you need to. Get
Yeah.
more visualization. The one thing the advantage with that is you can know maybe a little bit better how much pressure you're putting on that second molar if it's got spindly little roots, or you can see the distal better. So no, I mean, I don't think there, that's where the judgment comes in, and what works best in your hands. I'll say the one thing for me, um, you know, since if I do need more exposure, I'll just continue on with a sulcular incision up to the distal, the second premolar maybe, and then
Okay.
reflect that. And that's usually how I get the visualization that I need. And
Right.
I would say most of the time I suture, maybe, I mean, more than most of the time. I mean, almost all the time I put a suture in the maxilla. But sometimes, my assistant's handing me the suture. I'm like, no, we're good, because it just falls back together. And that's why, I mean, really, the point here is that a mesial release on the maxilla heals great, because
Yeah.
there's really no muscle pull. It just falls into
Yes.
place. And it's,
Completely agree.
right, so you don't have issues with that. Um, and then, of course, the maxilla heals so good anyway. We can get away with a lot up there in that
Yep.
area.
The other thing, just on checking the socket, one more time. This is a whole different topic, but it's just to really check for root fragments that were left. And sometimes we think that we're better than we are, and I will say, I mean, over time, I'm much more in tune, with my elevation, like any little sound or feel of like a crack, all of a sudden I'm very aware that, hey, I most likely got a root tip there. But I'm still surprised, even now, 15 years into practice, like there's times where I call it checking for a pulse. Like, did you ever see the movie Pacific Rim, where
I love that movie.
It's the same. It's one of my favorites. They light up
It's
that big
awesome.
monster and they start walking away, and then he stops and goes, "Let's check for a pulse." And he turns around and just like nails it with some more like plasma gun stuff. But I call it checking for a pulse. I just double check one more time, irrigate, suction, make sure no root tips are left in there. And still every few months I'll do that, and I'll be certain that I got the whole tooth out, and I'll check for a pulse, clean it out, and sure enough, there's like a 1-2 millimeter root tip, and I'm like, what in the world? How did I miss that? Boom, flick it out, and we're done. But how often some of those could be left if you're not double, triple checking everything before you move on. Any thoughts on that?
When I added to your document, I put in a tooth that was from this week, and it's and I put it in there again because I'm kind of, I guess I'm complimenting my assistants because they will check roots for me, and they will ask me, "Are check that root?" And 95% of the time, I'm right, and then 5% of the time they're right. Yeah. So the picture that I show um, was a tooth that, when it came out, I was um, very certain, if not completely certain, because of my visualization that I got the root out, but they wanted to be sure. So I put it on there. And I think that reading the roots too is part of this whole thing of reading the socket. Look at your roots. They always organize them for me on a 4x4, all the roots that are coming out, so I can put things back together if I need to. So you slow down. Like for me, it'll be like, if it's a difficult case, I'll slow down. If I've done a lot of drilling, I don't know what's left. There are times, maybe a couple of times a year, I'll take a periapical to make sure that I got the root out. And then I'm asking, I want them to be looking and paying attention and questioning, because guess what? The patient wins in those scenarios. And,
Yes.
And when I'm wrong, and, like you said, I mean, we get good. We get really good, and being good can be bad.
That's right. Too confident. Yeah.
Yes. And we need to have people around us where that we're okay with them, questioning us. And, that goes and that's really for us, it becomes our staff members, and how you have a hierarchy set up. Is it a hierarchy? Or are we all really on the same, is really the outcome, the patient-based outcome, the most important thing, or is it ego, or is it more of a surgeon down, or a more hierarchical approach to things versus maybe more of everyone's in this together, and there is no egos when it comes to patient care.
Yeah. Oh, I love this concept so much, of having your assistants well educated, well trained to just be a second set of very efficient eyes. Because, and I've mentioned on the podcast too, but I train my assistants, sounds like you do the same, to feel very comfortable to say, "Hey doc, let's stop." And you're about to, like you said, you're about to block 17, and that it's just 1, 16, and 32 on the panel, right? We're not doing 17. Oh yeah, thank you. Like, so that's a whole nother topic, is just creating that environment where people feel comfortable saying things like that. Maybe your hand is on the forceps and that's resting on a tooth you shouldn't be taking out. Hopefully your assistant feels comfortable, kind of giving you the signal, grabbing your hand, whatever it is, to say, "Hey, let's pause, do another timeout. Let's make sure we're all on the same," because it's not adding up for me. And sometimes my assistants do that and they're wrong, and I'm right. But I'd rather them do that and I must triple check it than whatever, take out a wrong tooth, inject in a wrong site, all that type of stuff. Very important. The other thing I was going to add to this is, I'm kind of titling, this talk we have, be a student of the socket. But I think what goes along with that is, like you're mentioning, being a student of the tooth once it's extracted. Because after that tooth comes out, I'll look at it, really closely, look at the roots. Does it look like any of the roots tips sheared off? That if I'm looking at that, and you can kind of tell that with experience. Okay, look, it looks like that distal root is probably still in the socket. Well, let's go check it again and make sure it's not there. Or let's say you take a maxillary molar out, and You got buccal plate, right, attached to those buccal roots. That's stuff you can learn from. Why did that happen? Well, what could I have done to prevent that? Should I have used some osteotomes, separated the bone more? Should I have, I don't know, use your forceps a little bit longer, not press so hard on the forceps when you're leaning buccal? So I think there's just as much to learn from the tooth almost as there is from the socket. Any thoughts on that?
Yeah, I think you said it. When it takes me a lot of in and out to get a tooth out, I that's when I don't know. I think that's when you really need to look and see what you need to change. Like I'm not saying that you need to just go in the socket one time. I remember that as a badge of honor. In residency, you just going in there, do everything at once, and then all the tooth. You get the tooth out, you've done your bone removal and everything. Sometimes you need to go in and out, and then um, and then uh, and really the only way to assess what you've done after is to look at the socket and then look at the tooth, because they just go together, and it kind of gets back to what you had talked about the surgical access, and what I mentioned about taking the bone or taking the tooth. So and really the tie-in there is instrumentation, I think, because as we know our instruments better, and we know the diameter of our burr, we know the length, and it becomes like a part of us. Then we can more adequately section appropriately without damaging bone, or we can, without going too deep. We can, it's like knowing your materials and making it. And I added to that to the document for you just the burr, which is I just use I use a 70 millimeter handpiece and burr, which is like a long WH, and I just find it ergonomically really good. Occasionally, if it's something else I need to section more into, I'll use a little shorter handpiece. But as your burr, and then part of this is feel too. So this case that I've put in there too was from yesterday, and I wound up doing a bilateral coronectomy on this patient, and I was getting no movement. I had a feeling I was going to be able to get one of them out. The other one, I did not think it was going to be feasible, but I wound up doing a bilateral. Just things were just not moving, and so both of these coronectomy, and that's another thing. Reading the socket after a coronectomy. Do you have the right instrumentation to do a coronectomy appropriately? And sometimes if the tapered fissure burr isn't all you need to get off all the enamel, and so that that's a specialized technique. I think it works really, really well, but it does create some, follow-up challenges and other things. But, we get the hard ones, and we need to know how our instruments behave in these areas, and so once I was first using this S11, this is what is this? No, this is the S10. I think I use it, WH S10. Yeah, and it's just, I don't know, for me, it just sits in my hand really well, and it's almost got a pencil tip to it. So it's really narrow. It doesn't have a light on the end like some of the other straight or even angled H. I love the light, but for me, this just works really good. And I put that long burr in it. I know the burr. That burr is a 702L, it's called. And they have a Brasseler also. This is a Brasseler burr. And I've also got the 703s, which one has a rounded tip, one has a much more squared off tip, and then maybe different lengths. But that's just what I use. And that's all of this goes together. It's not just one thing. It's not just when you're done. It's not just what does a tooth look like. You need to make sure your visualization is really good. And that gets back to, is your assistant trained properly? Is the patient anesthetized, or are they moving? Are they uncomfortable? Is there too much irrigation? Is there too little irrigation? What about bleeding? And sometimes you need to just stop and check the scan. If it's a difficult case, like in this bilateral coronectomy, I had to go back and look at the scan. So I keep the scan on my side. So I'll just go over there. I'll take off a glove and just manipulate the scan to verify where I am. It just takes a couple of seconds, but it'll just help you get the anatomy in your head. I think that most of the time, once we do our consult on a patient, then we review, most of the time we've got that, it's formed an image in our brain, of what's happening. And then we review the scan, maybe preoperatively again. or during the procedure to help us out, help us get through that tough spot, and saying, well, you know what, maybe I need to look at that again, and then make a decision based on that. So part of that is, like you said, is slowing down, not rushing through the end of the procedure, paying attention, learning from those different spots that you can throughout a procedure. Some cases have more learning than others, and then, is it, and that was one where I changed my approach to the left one. You can see in the X-ray I've included here, the left one I thought I was going to be able to take out, but the 32 was the photograph that I have, and that was the one where I had a feeling that was just not going to be a tooth that was going to get out completely, and the uppers stayed in this particular patient's case. So I don't know, and this is one I didn't include the CBCT, but of course this is one when you have these these teeth with hypercementosis like this. I mean, I really feel like you need to get a scan on it.
Sure.
You know what I mean?
Yeah, some of these patients, this looks like someone maybe in their 30s or late 20s. Like no PDL, looks like, kind of the picture of big bulbous roots overlying the nerve. These are tough teeth, man, when there's just no space to move the tooth, and it's like sitting in concrete bone, once you get that relatively older patient and not a teenager with flexible bone. So I think it's an important concept. I know it's not super glamorous, but I think it is an important concept to double check things. I love this concept that you're bringing up with the X-ray. I always have my X-ray, CBCT or PANA, whatever it is, up on the screen right next to the chair facing me. I'm looking at it because I think you can also sometimes, like you're mentioning, get into a false sense of security where I saw the X-ray, I know what's going on. Sometimes you double check, even like you said, take your glove off, scroll. I didn't realize that small nuance, but it's okay to do that mid procedure. If there's any doubt, that's when we gotta, any doubt, call it out, take some time and review it real quick. Much better to triple check than to make a mistake. This concept of, I think, learning from the socket, from the tooth, can be applied to other procedures we do, of course, such as, learning from a post-op X-ray on an implant, looking at it and in whatever 3 dimensions, if you've got that. How does it look? Is it too close to this tooth? Should I have, drilled deeper? I don't know. But always taking time to kind of do that self-analysis with any evidence you have that can kind of show you how things went. And you could do that with a post-op X-ray on the open reduction internal fixation, your screws and plates. I think you can even do this concept with the patient, let's say, that comes in 2 weeks later for a post-op check, and you even just ask them, how did it go? Well, it was really painful, I had swelling, and that right side was worse than the other. Just paying attention to those small things can teach you. And I do remember that technique I did, maybe I should alter that, and that would have helped. What are your thoughts on that?
I mean, I just really only have one thought on it, and it's when we're busier and we're constantly doing, we need to stop and learn. There's I think those of us that want to learn so much before we do, me being one of them. You want to keep you want to keep going, and you're busy, and you're doing all this, you're really keeping your practice going, and you're doing all this other stuff, and you need to stop and learn to do it better. I would say that one of the best ways to do this, and it's such a simple thing, and I've mentioned this to doctors before, and I've had very few take me up on it, but the doctors that I work with, I want them to be taking out teeth. And I want them to be good at it, because they're going to be taking out teeth, and I'm there for them for harder cases, and I'm fine with that. And a dentist should be doing everything that they can do and of course the test for that is, can you do it as good as a specialist? And I think that the only way you can is by doing it. So it's like, I think dentists sometimes are caught in this trap of, well, I can't do it maybe as good as a specialist, so I'm not going to try it. Well, that's not really growth or learning either. What I'm getting at is that to really take it to the next level, it might only, like on a specific case, it might only mean coming to, go with the doctor that you collaborate with, call them and go, the case you're involved in, say, hey, I'd love to come by and see this case. If it's a surgeon, I'm sure that you and I are aligned on this. I love that. I want them to come over and I want to teach. I want them to be better, to give better services to their patients. And if there's anything I can do to help, I want to do that. That's what, look, being a doctor is about teaching, like that's what we
Yes.
need to do. So, and I'm going to leave you on this. We got to teach our assistants too. Like they need to be taught like students too, because as they're taught, and we this analogy I have, there's a local coffee shop, and his interview process is crazy, and he spends like 3 days interviewing them, showing them around how to make espresso, how to grind the beans, which beans you use, what how do you tamp this down, and how do you use the espresso machine and make all these drinks and everything. It's amazing to me how much time he spends. Now, all of his staff members are very highly skilled, and that's why I always go back, and they're always friendly, and they're the right people, and they have buy-in. I will say that we don't really have a lot of luxury with maybe who we can hire and train. Meaning, it isn't like there's an overabundance of people that want to work with us. But people that we do have, I think they need to ask questions, and we need to answer them and train them, because as they're trained, they become very skilled at helping us deliver good care. So it's learning, it's doing it better by seeking it out in your local area with surgeons that you have a relationship with, and then training our staff, taking time to train them and talk to them and make sure they're asking you questions. And if they do, you take time with them. It is time really well spent.
Completely agree. Yeah, with all that. But yeah, I'm very passionate about that topic as well. Training your assistants, empowering them, educating them. Because in the end, it's just another set of eyes that can really help you, help the patient. And the concept too about teaching, our referring docs, the GPs, I think I've always felt that's important. Let's face it, there's going to be so many times where this GP is with a dental extraction guy in pain on a Friday at, end of the day. And that's that patient's real hope right there, is like having a good dentist to take that tooth out in the chair. There's just many instances where it's infeasible for them to get the patient to us, unless it's days of extra pain. And so I think it just benefits our patients, all of us, to teach. Everyone's getting better at what they do. So I know there's maybe that worry that, they get too good and they stop referring to us, but that's never been the case in my practice. In fact, it's the reverse. Like the more I'm generous with teaching and my knowledge, the more they'll come back to me and lean on me, for help and send patients to me. They just feel more comfortable in that relationship.
Yeah, well, it's a patient-centered approach. It isn't a selfish, what am I getting from this approach? Or what am I not getting from this? Or what am I potentially losing? Who cares? In the long run, it doesn't matter. Really, what we need to judge ourselves on is what have we done to take care of patients better? And that isn't just our patients, it's all the patients that we can, that's our calling. And if we can help, like you said, if you can help a dentist deliver better care, what's better than that?
Yeah.
That's what our life is about. That's what, I really think it's our duty in a way. And if you just step aside from any other implications that come along with that. And one doctor told me this. I said, man, I wanted you to come over is because he would always ask me questions at some of the study club meetings. He's like, well, I just didn't really think you meant it. And he's very forward and blunt. I love that about him. He'll just tell me, he's like, yeah, I just didn't think you really meant it. I'm like, dude, I want you to come over. I want you to be better. I know you're placing implants. I'm fine with that. There are certain cases you need to place in your practice because that is within your practice and you need to get good at those things. And I want to help you with that because I mean, how is that helping anybody if they're working in this solo environment and they don't have anybody to bounce things off of? The patients aren't winning in that, and I want them to deliver good care too. So, anyway.
Yeah. Well, I really appreciate you kind of fleshing out this topic of learning, from the whole process of taking some time once that tooth is out, checking the socket, checking the tooth, once that implant is in, looking at all the signs there that could teach you what went right, what went wrong. I think it's an important lesson. I think we're taught this to some degree in our residency, but it's something I think you really also have to kind of get good at and master and take time with. And so hopefully this helps our listeners. Hopefully, at the very least, it's food for thought and they can start kind of experimenting with this. Any other last minute comments on it?
Just one other thing comes to mind, and that has to do with the perfectionism tendency, I think, of all of us in dentistry. And, it's being humble enough to know that you're doing the best you can do at that time. I mean, it's humility about yourself. It's knowing that I can do it better next time doesn't mean that you didn't do it as good as you could do it at that time. I think all of us looking, you know what I mean? So all of us can get better. And that's what we're searching for. It's, everybody says all of us are a work in progress. And part of that is learning from each of our experiences with our patient and all those little nuances that go into us providing things better, but not being, and I was so many years, and I made so many mistakes in my career. And one of them was, you do not get much satisfaction from perfectionism, so we don't use that term, in my practice. No one ever says about me that he's a perfectionist, but but see that I care. They know that I want good outcomes, because that to me is that's a quality that can be very, very difficult to live up to. Well, impossible to live up to, right? And I think that a lot of us as dentists are prone to that, and that really has to do with many professionals. It isn't just dentistry. It's the seeking perfectionism is not ideal. So that would be the only other thing I would say. So.
Yeah, to me, it's like what you're saying is having that mindset of learning and not being too hard on yourself. We're all trying our best, right? I don't think any surgeon does a surgery and is like, well, I'm just gonna go 80% on this surgery. We're doing our best, and then we review it. What could we have done better? Well, let's try our best on that next time. So it is important to keep a good mental status and not be beating yourself up, because there would be plenty to beat yourself up about, and I don't think that's helpful for our patient. We got to maintain a good level of confidence and humility. All right, Rick. Well, thank you for your time. I look forward to doing future episodes with you, and I appreciate you sharing your knowledge on the podcast today.
Oh, it was great, man. Great subject, great discussion. Thanks so much.
I appreciate you. All right. Well, have a good weekend. Have a good rest of your day.
Okay. All right. You too. Take care.
Thank you so much for listening to this episode of Everyday Oral Surgery. For more information on these podcasts, please visit everydayOralSurgery.com. I love feedback and would be very grateful if you would reach out to me via my email, grantstucki@gmail.com, and let me know what you thought of this episode. Or you can text me at 720-441-6059. Additionally, if you have any topics you'd like to hear about, or if you would like to be a guest on the podcast, please email or text me. I found many of my interviewees through people who have been contacting me and I've been listening, and I've gotten so many great ideas for more podcasts, and that's what helps keep the podcast rolling. So I really appreciate you making that extra effort and helping me out with feedback and knowing what to do next on the podcast. Thank you so much.